We're going to go right into questions and answers. We only have a half hour. Please make the questions very brief, and I promise our responses will be very brief. Feel free to take a stretch if you want while this is taking place.
The question, and I hope Dr. Glath is going to jump in here, but the question was the withdrawal of ventilator support in Catholic teaching related to the withdrawal. And if I can just, one of the things that has really brought this to the fore has been the pandemic, the concern in our country with the respiratory pandemics. We kind of dodged a bullet this time, but the avian flu is really out there, and you know, that's 50% mortality with the avian flu and our ability to have sufficient ventilators. They're facing that in Haiti right now, There is a system in place that we have looked at and actually have put on our web in terms of major organ failure. And if you go on our web, the Indiana Health Department has actually come up with a draft that we looked at. And it's a whole system looking at how many, and this is too long of an answer, but organ failure and immediately exclusion criteria such as inhalation burns, affected by burns. And so a whole system of grading patients in terms of who's going to benefit. It isn't about their quality of life, but are they going to benefit from this ventilator, especially when there's a shortage of them. And then they look at the patient in 24, 48, 76 hours, continue to grade, and actually scores provided. I think that is morally licit because but we still have to have consent. But if we're looking at benefit to burden, and are we going to initiate a treatment that in the long run is not going to be beneficial based on solid criteria, organ failure, they look at major organs, bilirubin, creatinine, etc. I think it's morally licit.
Thank you.
Same thing, yes. They score and they would withdraw if the benefit is not there. Dr. Glath, are you?
Just briefly, from a medical perspective, we've got lots of situations where we have folks that are on a ventilator where we say, we're going to discontinue the ventilator. We think it's increasing the risk for mortality because of the higher rate of pneumonia, et cetera. And so there are lots of other reasons to think that the ventilator may not be providing the benefit. And then when we take the ventilator off, people breathe fine. We don't always anticipate that that will happen, but occasionally it does, and we're wrong. On the other hand, we think they're going to breathe fine, and we have a lot of trouble weaning individuals, and it requires a much greater effort in some circumstances where they start to come off. And you in critical care know you go through this all the time. And you have your parameters that you set up that say they should be able to wean, and you try it, and lo and behold, they can't wean. And so then it may be related to medications, it may be to other things, and so you have a challenge in front of you in terms of trying to determine what do we need to modify to give them the optimal chance of being able to survive without the ventilator. That's just the medical perspective. In terms of how you determine who is going to have the best likelihood of getting the greatest benefit with or without the ventilator, those are all medical decisions, and some of those models are out there, and you work with them all the time, I'm sure, in terms of predicting that. I try to tell people, though, that we are fallible, and you see it all the time. We think that one thing is going to happen, and something different happens, and so we don't always know. And I think that is one of the areas where, as a medical professional, you make sure that folks understand what we don't know as much as what we do know, and that's where I think that invocation of prayer becomes really, really important. And as medical professionals, we give them some guidance in terms of what we know medically. We also, it's okay for us to say, I don't know here, I don't have control here, and we'll see what is God's will, and I'll pray with you, and we'll come to a conclusion. And from a medical perspective, that's where I go.
Thank you, Doctor. Yes. Yes, please.
I come to this from an entirely different life perspective. I come to this from the perinatal area. And we've heard lots today about no abortion and families with, that we don't believe in abortion. And that families who have babies who have a terminal problem with supportive care, with treating that room as the hospice. We have hospice care for elderly people, sick people, but we don't really have hospice care for families who have that kind of issue. And I see it kind of as a gap of care for families. Continuing that pregnancy, having that baby in a family can be a wonderful event, but we are so good at telling people what's wrong with their baby and you can't fix it. And so, so many families are faced with terminate this baby because it has this problem and there's no support there for them other than that initial diagnosis. And so I see it kind of as a gap we have to kind of fix. And just kind of really not so much a question, just kind of, we need to think about this because if we're asking people to not terminate, we need to help them now.
Good, thank you. Dr. Gloth, who would like to attack that?
Let me just make a comment about that. I think the difference between a culture of life and a culture of death is precisely what you mentioned. That is, if you're going to assert a culture of life, there's also an obligation, I think, to try to make that occur. And this area of, I take it what you're saying is there is an ability to make a diagnosis that a child is going to be born with a certain disability, but then the family is more or less left to their own devices. Yeah, that's very interesting. I once gave and that needs to be addressed. And I think Catholic hospitals in particular, just as they should not let anyone die alone, they should not let any family have to struggle alone with these kinds of difficult issues in caregiving for infants and so forth. I once gave a speech to a Christian medical association in which I talked about the importance of human equality and et cetera. And a young man came up to me and he said, I'm a genetic counselor. What am I supposed to do when a mother, I have to tell a mother that her fetus has tested positive for Down? And I said, well, how about bringing in a family with a Down child that can describe the entire situation as opposed to saying, oh, it's a terrible situation, better terminate. And he looked at me like I was from Mars. I think there's a lot of education going into there is only one choice when there, a rational choice will say, when there is this situation. When in contrast, I think that people who do have this experience offer tremendous wisdom to help people in this particular circumstance. So I applaud you for your work, and I also think you've raised a very important area of the gap that needs to be filled.
Dr. Fisher.
To add to this, there is in fact neonatal. To add this to this discussion, there is in fact neonatal hospice nationally now available and developing. There is a doctor who's spoken to the Catholic Medical Association on several occasions, Dr. Calhoun, Dr. Byron Calhoun, who has established neonatal hospice services. I think he was a former military physician who saw the need because he dealt in OBGYN, I think. And he saw the need for this, and he has established hospices and would probably be accessible. So there is efforts in that way. It's just not well known.
Yeah, certainly. I work in Howard County at a public institution and received a grant from an institution in Howard County to begin a perinatal hospice program. So there is, I am working toward giving that idea legs, but it's coming from a small community. It's not coming from our church.
And you know what's really concerning is if we fall prey to this idea of the life not worthy of life, the attitude will be, well, we already know the solution to that. Why should we spend the effort and the money and the resources, both human and financial, to create such situations when we have a much quicker and easier and cheaper solution? So that's a real problem if we don't defeat this culture of death.
Thank you. Any question further? Yes, please, Dr. George. No, next. Sorry.
Thank you, Archbishop. I'm Dr. George Isai of internal medicine, been practicing for 35 years. I think it's a very good idea to point out how there are certain misconceptions or generalizations that may be inappropriate, such as, the treatment with narcotics causing addiction in these elderly people and so forth, which is very good to point that out, and that physicians sometimes will not give appropriate doses of narcotics or will not manage the patient because of their preconceived conceptions. But I think it's equally dangerous to go the other way and to make claims like that would make it look like CPR is always bad, feeding tubes are always bad, or intravenous hydration is always bad. For instance, I have the experience in many cases of very, very good beneficial treatment with feeding tubes for years and years with patients who are appropriately selected for that. The idea is you have to know how to select the patients who will benefit from it. Recently, Dr. John Howland published an article in the National Catholic Bioethics Quarterly, the previous issue, shooting some holes in that evidence-based medicine that says there is no evidence that feeding tubes are helpful. If you remember years ago, there was no evidence that smoking causes any harm. And we had published medical journals saying there is no evidence to that effect. And how wrong were we then? I once had a NIH researcher tell me that if you tell me what outcome you want from a study, I can arrange it so that you'll get that outcome. Anyhow, I don't know what the motivation would be for promoting this thing that tubes are not beneficial. There may be some motivation in terms of government saying that it's more costly, people live longer, et cetera, but I'm not going to pass a judgment on that. But I can say that, yes, if you're selecting your patients for aspiration, you're likely not to get a big benefit. But there are patients who are demented, had the need for that reason, kyphosis, hiatal hernias. I had a patient that was on hospice who absolutely would not provide tube feeding. The diagnosis was failure to thrive, losing weight, went down to 76 pounds, partially demented, partially because of kyphosis and hiatal hernia, was not eating. I suggested the family to get the patient off of hospice. We put a feeding tube. The patient died 6 months later in very good health, regained the weight, then had congestive heart failure, unrelated cause, died from it. Never aspirated, never had any problem. Sure, there can be benefits, but the danger is equally to say across the board, these are never beneficial, and then don't use them when they are beneficial, because what happens is, yes, then the patient dies, and nobody ever knows that they would have been beneficial in that case.
Okay.
Now, when you use them inappropriately, and they have a problem, then you know that's a problem. So you have to be careful in judging that evidence. Thank you very much.
Thank you, Doctor. Any comment?
Sure. Just very briefly, the lack of evidence, and I mentioned, is in conscious individuals. There's a great benefit to feeding tubes in somebody who's in a persistent vegetative state. In conscious individuals, you do increase the risk of aspiration with any feeding tube, whether it's G-tube or otherwise. You need to understand the risk versus the benefit. It's not to say that CPR is never useful. As I mentioned, the cases where it is useful generally is in a monitored situation, but you want to make sure that people are making informed decisions. And many, many more times are people making decisions thinking that there is a benefit, where indeed there is no evidence that there is a benefit. In fact, that there is evidence that it is harmful. And so whenever we come to medical decisions and we're wrestling with the ethical portions of things, we need to make sure that the information that's being provided is accurate. And so one of the things we steer away from a little bit is anecdotal experience, which you've given us a few anecdotal experiences that you've had. But it's really important that folks understand, here's where we know there's benefit, here's where we know there is actually harm, and there are going to be gray areas in all situations, and you'll have to do the best that you can in those circumstances.
Thank you. I think, can we keep going?
I'd be happy to talk to you more about this.
Yeah, okay, fine. Yes?
And I'm retired. But anyway, you know, talking about feeding tubes, we've had patients there who've been on it for years. And, but my question is about hospice. We also have a lot of patients who are hospice patients, and yet they choose to be full codes. Now, I thought that was sort of an oxymoron. I thought hospice was end of life, and yet, you know, there are organizations that accept these patients as full hospice patients. but they're full codes.
For hospice, and with the feeding tube, if it's something that's being used for supplementation and the individual can't get enough calories in otherwise, sometimes that will be useful and helpful. You still increase risk, but there may be a benefit. With CPR, it used to be that you couldn't take someone in a hospice if they were CPR. It has been recognized in that cardiopulmonary resuscitation for some individuals is something that is a preference. There is a recognition of the low risk, and hospices have become a little bit more lenient in accepting individuals that also have a CPR. It is somewhat counterintuitive in terms of the benefit. And unfortunately, in many circumstances where families want to have CPR, there is a misunderstanding of the benefit. There is, in this state, something called medical ineffectiveness, or some people will describe it as medical futility. And so if a family member feels that, and the term you hear oftentimes is do everything, there are clearly times when doing everything is not going to be medically useful. And if we know that it is not going to provide a medical benefit, there is, in our laws in Maryland, a way that if two physicians, including one of them being the attending, recognizes that something is not medically beneficial and has the potential to cause harm, they can certify a procedure, whether it be a renal transplant, CPR, other things like that, as medically ineffective. And if they designate that to be medically ineffective, then staff will not be forced to do something that may be harmful or lacking in benefit. And so that is an option that you have for folks that may want to do things that are counterproductive, counterintuitive, and likely to be harmful to them. Those decisions sometimes are made by folks that have an ignorance of the benefit that can be provided. And again, the dramatization you see on television and other venues sort of give us a false sense of what things can do. And so when that happens, there is an out that's available through the law.
As the doctor says, it's a balancing of benefit and risk. Now, if one can't feed themselves, there's a grave risk of starvation, of course, and that's an immediate concern. You try to give them nourishment. Now, you may recognize there's a competing risk of aspiration or other complications, but there is an immediate risk of the starvation too. So you're trying to get nutrition to the person. As long as you can provide nutrition, it would be considered ordinary care. If there were significant other risks, then a judgment would have to be made balancing them. But also, I'd read an article by, it was the dean of the Spalding University, Dean of College, Health and Natural Sciences, but he said often we put people on feeding tubes when they don't need to be yet, but we're not willing to give them perhaps the intensive nursing care, and so we put them on the tube, and that creates a complicated situation for the family. And that would really be a call out to particularly Catholic hospitals to try to make a commitment, because in a sense, artificial nutrition does kind of lower our dignity. You'd like to feed yourself by mouth if someone's willing to take the time to do it, even if you can't eat a lot, just a little bit regularly. I remember, just anecdote, but visiting a patient, and she couldn't raise herself up. She was laying in her bed, and she had a full tray of food and a big cup of water. And she said, I need a drink. And if she touched the cup, it would have spilled all over her. So I had to go out and ask for a straw, and then I came in and I fed her, but no one was, I mean, that's hopefully an exception, but case being, if we are willing to make the commitment to care, sometimes the artificial feeding isn't even required. But also, again, for someone in a coma or vegetative state, they can be fed. It's assumed that they'll be fed. Someone who's facing a terminal condition, you arrive at a judgment. How soon is death approaching? Will the nutrition be necessary? But also a case where someone perhaps is a relative who was paralyzed, so confined to a wheelchair, paralyzed except for wrists, couldn't control throat muscles, couldn't swallow, but had a feeding tube, and it was very effective. You know, we'd be speaking to him, and then he said, excuse me, it's time for lunch, and then they come and plug him in, and then he would resume the conversation. So there really is a broad spectrum of possible situations that you face.
Thank you. Yes?
When we talk about medical futility, and sometimes called fetal care theory, we have to be careful, because I think medically inappropriate futile treatment, medically inappropriate, obviously is something that can and should not be provided. But there's also a movement afoot to deny what is called qualitative treatment. That is, The idea that, well, grandma, she's had this stroke and she's probably never going to be able to live independently now. And so even though this feeding tube, we'll just use that as an example, might keep her going for a couple of years, what's the point? And it strikes me that one way to try to judge the difference between medical, and this is, again, nuance is required. See, the problem is the culture of life is nuanced and the culture of death isn't. And yet the people who purvey the culture of death say we're the ones who aren't nuanced when they're the ones who are blunt. But excuse that aside, I get tired of that. Let's take a look at the Terry Schiavo case. Let's assume that Michael Schiavo and the Schindlers had agreed that Terry should be maintained, and certainly everybody on this panel would have thought that that was beneficial treatment and so forth. But there are people out there many people out there who would think it is not, primarily because she was either in a persistent vegetative state or a minimally conscious state. And let's say that some doctor said, this research, the resources are too much. She's been in this condition for 12 years. You often hear there's no prospect for cure. There's no prospect for improvement. We want to stop the feeding tube. Now that would be a pretty broad example of a qualitative futility where the treatment wouldn't be stopped because it wasn't going to work, but it was going to be stopped because it was working. And then of course there you end up in a place where there's a gray area. But I do think in medical futility, and I'm noticing this in Catholic circles particularly, I think there is some confusion about this issue of medical futility. I also notice that this happens certainly in Texas, that there's a difference, when the question about whether a treatment is extraordinary or normal or ordinary. By the way, that's not a legal standard, that's a Catholic standard. That they'll say, well, we should be able to stop this extraordinary care. But I think it confuses with the right of a patient to refuse extraordinary care and the right of the physicians and the hospital to refuse wanted extraordinary care. And I think that in terms of Catholic thought and Catholic writing, there needs to be some more analysis of that to help educate, because I've been very worried about, am I speaking out of school, Archbishop? I hope not.
That's not for me to judge.
I think the Catholic bishops have gone in the wrong direction, and I'm afraid the Idaho bishops, because there's a feudal care law pending in Idaho, may be going in the wrong direction. That's way above my pay grade. I hate to use that term. It's been ruined. But I think that there needs to be some more clarification for Catholic audiences in that field.
We only have 10 more minutes, less than that. Dr. Hilliard?
Just quickly, there are a Texas law that we just heard of, unfortunately mandates that after 10 days, and they're trying to extend that, if the hospital and the family cannot agree in terms of treatment that's not only futile, but the case of Emilio Gonzalez in Texas was a little boy, 18 months old, who his mother insisted he stay on the ventilator, and he was actually being hurt. He was suffering. The care was more than futile. It was causing him suffering, and it went to court. He died without that being resolved by his heart finally stopped beating, whether he was on the ventilator or not, and so it was not resolved. But out of that, the Texas legislature created this futility law that if a family can't find a place in 10 days that will do what they want, the hospital can stop providing, including assisted nutrition and hydration. And just to speak in favor of the bishops, I know in Texas they're working very hard. And it's a two-pronged thing. We work with the legislatures, but we also have to work, as we are here, with the people of God. Good discussions, and that's what Dr. Gloth was really speaking of, with families, can avert a lot of this that we're hearing of.
Thank you. Yes?
I'm not a medical person. I'm part of the laity, and I think that...
Microphone.
What I have found is that there's more confusion among Catholics, like how do you deal with an elderly person? In other words, is it now church teaching that you have to put a feeding tube in them? I mean, I think people are a little confused.
It's a medical problem. I think we've been saying that pretty consistently, primarily, but certainly... Okay.
It's probably most helpful to recognize that a feeding tube is not always useful. And so that, I think, is where the confusion comes. For most lay people is they think that a feeding tube is always something that has to be done. And I think one of the messages coming across today is that that's not always a necessity. And so there are some options that are out there. And in fact, sometimes, because it's likely to be harmful, it actually may be something you should avoid. So it's that there are always going to be gray areas. There are a few that are much less gray, though, and we're trying to, I think, put some of those forward to help folks out. The issue in terms of Catholic teaching versus what's going on medically, the two are very much in concert. And that's, I think, one of the things that we're hoping to accomplish today is that a lot of things that the Catholic Church teaches isn't a conflict with what's happening in medicine. There's actually some unification in terms of thought processes. While we may talk about things for a medical reason, that issue of benefit and harm is very in concert in terms of what the Catholic Church teaches. The Terry Schiavo case actually creates another issue, not just the feeding tube. What was most disturbing for me about that is when they took the feeding tube out, they refused to allow them to try to feed her. And that is much more disturbing in my mindset, because if she actually could have swallowed, if a primitive reflex was there, she probably could have been kept alive with feeding. And no one was even allowed to try that. And that, to me, is a very, very disturbing part of that ruling.
They didn't even allow them to give ice chips on her lips. There was so much there that we could spend a whole day on.
Yes, sure. Microphone.
The document 5 wishes and also the term eminent.
Yes, Dr. Hilliard.
Imminent is, I'll do the easier one first, maybe not so easy though. Imminent is best medical judgment. No one has put a time frame in there. What we say when the calls come in is basically, especially in terms of assisted nutrition and hydration, is the person going to die of the underlying pathology before they die of starvation and dehydration? That's our rule of thumb. It's not, but even if that's true, if someone keeps aspirating the tube feeding and it's still being, the little that's being assimilated is beneficial, but if they're still aspirating, then we have a disproportionate burden to benefit. But our rule of thumb with imminent, because it means that the underlying pathology, not the withholding of some therapy, is going to kill them. And that's what we look at as our rule of thumb. And I didn't.
In Maryland, the Healthcare Decisions Act uses 3 terms. One is persistent vegetative state, the other is imminent death, and the other is end-stage condition. And for certain portions of the law to come into effect, you have to fit into one of those 3 categories. Imminent death usually is death that is anticipated to happen within hours to days, at least as it stands in the state of Maryland. It actually varies a little bit in different states from that perspective. So there is a legal term to imminent as well as the definition that you just heard. So having said that, I think most people in Maryland look at this because of the issue as it applies to the Healthcare Decisions Act. You asked a question about 5 wishes. There are lots of advanced directives that are out there. There are lots of models and templates that people can use. If you go to Maryland's state website, they even put one on there for the Office of the Attorney General. So you heard about the one that's, I think, available through the Catholic Church, and that Maryland actually has a very good set of advanced directives that are helpful. I very much agree with all of the other folks who have said less is better. You want a person who is going to make decisions the way you would make them, and if your spouse has one belief and you have a different one, get somebody else to be your healthcare agent. That is much more important, and to have very cumbersome living will directives that say do this in this circumstance, do that in this circumstance. I agree that I've seen too many cases where you just can't predict every scenario. And so identifying a good healthcare agent and identifying a priest to get involved with you as well, I can't think of better advice in terms of making advanced directives.
One more question, if there's anyone. Yes.
Dr. Hilliard, is the information for accessing the consultation line in the materials that we received today?
I haven't looked at the materials you received today, I'm sorry, but...
How would we access it?
Just call our phone number, and I'll just 215-877, I'll repeat it, 2660. It's 215-877-2660. And there's a ethicist, a doctorally prepared ethicist, available 24/7. We would ask you after hours, only the emergencies, please, although sometimes they do ring at 2 in the morning. But our office hours are 9 to 5. I'll repeat that one more time.
Thank you.
215-877-2660. And many times what we do is ask you questions that are specific, because there is not a carte blanche answer. And the questions that you've been asking, particularly in terms of everyone thinks the church always requires assisted nutrition, hydration, or in persons with dementia, it's never beneficial. Those aren't true statements. So we try to tease out with the information you provide to us an answer that will be helpful to you.
Thank you, Doctor. We'll conclude our program now and extend special thanks to these local Catholic hospitals which have made the event possible through their generous sponsorship. St. Agnes here, Bon Secours, Baltimore Health System, Good Samaritan Hospital, Mercy Medical Center, and St. Joseph's Medical Center. We thank the leadership and staff of these hospitals, as well as the Catholic Medical Association, who have joined us today, especially Bonnie Phipps, President and CEO of St. Agnes Healthcare, Patrick Much, Vice President, Strategic Physician and Program Development here at St. Agnes, Sister Ellen Capria, Vice President of Mission Integration, St. Agnes, Dr. Adrian Long, MD, Executive Vice President and Chief Financial Officer, St. Agnes, William Jaskovich, Vice President, Operations and Campus Construction, Jim DuBois, Vice President of Mission, Bon Secours, Baltimore Health System, Sister Mary R. Scopel, Director of Pastoral Care, Bon Secours, Dr. Marie Albert Boursiquart, President, Baltimore Guild of the Catholic Medical Association, and Dr. Louis Bresky, President, Catholic Medical Association. I want also to thank Joanna Coughlin and Linda Brennigan of our own Archdiocesan Respect Life Office, who organized and staffed this event in coordination with the Chancellor of our Archdiocese, Dr. Diane Barr. I ask you to take a few moments to fill out the bright green evaluation form in your bag so that we can ensure future events addressed to your concerns as Catholic medical professionals. Please leave that form on your chair or hand them to the at the registration table. If you'd like nursing CEUs, you must also turn in the evaluation provided to you when you signed in. Certificates for CMEs for physicians and CEUs for nurses are available at the registration table. Thank you for joining us. Special thanks to our excellent panel. I think they've done a marvelous job today. Thank you.